All right, I'm going to call us back to order. People are wrapped and swaddled in many layers of clothes and scarves, and I'm perfectly comfortable. Aren't you, Gopal? How are you? So, being an epidemiologist, I'm noting, and we want to be agile to trends, right? So here's an observation. I've been noticing in very rapid time frame that men have abandoned their ties. They'll wear a $3,000 Canali suit but no tie. And this is interesting that in the room, the only people wearing ties who are people who have something to do in some way with the government or the VA or whatever, and me, because I adopted the persona of the, which is a really dangerous trend. So I congratulate all of you who are part of the new wave.
There was evidence of collusion. We discussed this at dinner last night.
I think it's really good, except, I spent so much time getting ties that went with this and that and everything that it's a shame to abandon them. So we were, if I'm not mistaken, about to get Barbara online, and then we were going to go around and catch others. And just a reminder that Joel presented the data issues and analytics issues, and so that thread's going to be important to keep our eye on. But if you've got broader, more general comments in this first round, we definitely want to hear them. For example, I thought some of the comments around agility and core values of HSR and so forth were really, really important for AHRQ to hear. But Barbara, what do you have in your mind?
So this has been a really a very interesting conversation, and I'm going to try to regain my train of thought. That's the challenge of right, coming in right after the break. And what I'd like to talk about is through the lens just from where I sit in a state healthcare agency, and one that's focused on safety, which is always in many ways been kind of the stepchild of the quality universe. And we could talk, and I know Jeff Brady would concur with me that it's in many ways we think safety is sort of the doorway to quality improvement. But we will, but I digress already. So I want to talk about just the challenge of the availability of safety data, data that you really need to support this conceptual framework that I totally agree with Bob is lacking not only on the front lines in the healthcare provider world, but also in the conversations we have and some of the work we're doing among policymakers and the general public. It's people really don't know how to think about patient safety. In fact, it's not even a term people understand. So part of the issue, and it's just one part of the issue, is that there aren't a lot of terrific safety metrics, safety measures. There are problems with many of the measures that exist for all kinds of reasons, and I don't have the answer to those questions except to say that that the metrics we have really don't answer the most obvious questions that people have or support any kind of a narrative that you'd want to deliver around, what are the key what are the key challenges in safety, what are the trends. We know that there's wide variability among providers, peer institutions, but we can't effectively measure those, talk about those. And so we're reduced to using data, very, very small data sets, really signal data, which I think can be very useful. And signal data is real data, but sometimes it's hard to just with that limited data to engage the people you need to get them to the table to talk about the issues and to work on quality safety improvement initiatives. And I can just give you just a very brief example in Massachusetts. So we, a couple of years ago, piloted a process using adverse event data. We call them serious reportable events in Massachusetts. So the 29, I think we used 29 of the NQF adverse events. And we had noticed an uptick in the number of events being reported related to cataract surgery in the state over the past year. But we're talking about 10. It was about 10 adverse events. But they were serious. They involved blindness. They were wrong patient surgeries, wrong side surgeries. And so we reached out to the professional societies for the ophthalmologists and the anesthesiologists, because some of these are anesthesia related, to engage them in a process. And we came to them with those data, those 10 cases. And the initial reaction was, well, what do you mean, 10 cases? You know, we do tens of thousands of cataract surgeries in the state every year. 10 cases, well, you know, I think we should declare a victory. We're good. But we continued the conversation. And, you know, what we did was we reached out, we went out to their various national registries and have little bits of data. So we gathered, we did spend time doing data, share data use agreements with them, and you get all this data that of course you can't link together and it's very incomplete. We even went to the malpractice carriers in the state, got some of that data, and, you know, cobbled together enough to say, and basically to say, you know, we could keep going. If we look, we will find, but there is a pattern here. And honestly, it was the narratives around the 10 cases, the actual stories of what had happened, which was what got the engagement, got the partnership. Fast forward, we did a very involved process that appears to have actually had an impact on practice in the state, which is hard to do. So, but, and that's just one example, but we confront this every time that we want to engage the front lines or anyone else around a safety issue that we're seeing, that we're detecting through signal data. So I don't have the answer to this. We are going to, at a state level, convene a process this year to get together all the stakeholders to take a step back and say, let's not worry about the data that we have or the data that we could link together if we could only agree to do it. But let's look at the questions. What would we want to answer in a perfect world? If we were to start from a blank slate, what would we want to be measuring? Because we know we're measuring things that we probably don't need to be measuring, and then we're not measuring a lot of the things we do. And I mention that because we're going to do that on a state level, but that's a conversation that and we're uniquely situated to do it at the state level, but that's the kind of conversation that AHRQ is uniquely situated to be doing on a national level. And if AHRQ were doing it, we wouldn't have to do it, or we would build off of what AHRQ was doing. So those kinds of sort of deep sort of strategy and planning discussions that then states as you know, one of your I think key target audiences. And I know this. I know that you know that states are a big user of AHRQ resources, but so I would even add a slide or lump us into the federal sort of the government users of AHRQ resources. But that's something that it would be wonderful to see more of, and I think the demand, you would find that the demand is there. So.
Thank you. Just a quick question for AHRQ. When you talk to your constituents about quality and safety, a lot of AHRQ's work's actually in safety. And so how do you frame that? I find some confusion about this. People talk harm all day long, and they think that, and some of them, that's for them quality. But so how do you, if you don't mind, just...
May I call upon my colleague here? Please, Dr. Brady.
Sure. So the question, how do we talk about safety?
How do you, for people who are here all day long, we're killing people, harm, patient safety indicators, it seems that AHRQ is very much associated with that aspect of quality. How do you portray the rest of quality in data analytics, AHRQ grants? How do you do that?
So first of all, I really like Barbara's comment about, safety as a doorway to maybe the rest of quality. I've talked about an on-ramp to quality. And I think I can actually relate it to the learning health system conceptual frame that, some of the same, most of the same competencies at the individual, organizational, and system level that we're applying with some success to safety are also very applicable to other quality problems. And so, I mean, that's a pretty simple concept. I can actually also connect that to the burden issue. I mean, I think one of the things clinicians are burdened by is quality and safety improvement people, right? I mean, the joke that I've observed is that, if you're a frontline clinician and you see the quality or safety person coming around the corner, you're going to duck into the nearest hallway that you can find, because it probably means more work that you just can't tolerate. And so we not only talk about that when we're doing our safety work, but we try to bake it into our research and our solutions that we put out. So, and I think, there's not only receptivity in terms of, awareness of the challenges that are really out there in the field, but these are practical considerations that we just, work into our projects. Does that?
So also, let me just add a couple things on, because I think it's a combination and a balance between quality measurement and quality improvement. And so we have some depth of competency and knowledge on the measured development domain in particular. And certainly the quality indicators might be one example, but the way we do that on the measurement side is often in collaboration with other partners, and especially CMS as a federal partner. And I'll mention one example, which is the Pediatric Quality Measurement Program, which is a program that has been in 2 phases, and we're in its 2nd phase now, in which the first challenge was to develop measures that would be relevant and useful in the Medicaid and CHIP programs to improve the quality of care for children. And we realized in doing that program with CMS that we did a great job of developing measures, and those measures were primed for implementation. And so we're now in the 2nd phase of that project, in which we've a series of, I believe, 7 grantees who are, again, in collaboration with CMS, doing some demonstration projects to actually implement and demonstrate some impact from those measures that were developed in the 1st phase. And then the third thing I would say, in addition to sort of the measurement, 2 activities on the measurement side, is that we do foster some quality activities through our extramural grant program. And a lot of times those are demonstration projects, but they cut across some of the domains of our streams of funding, whether it be in the patient safety, as Jeff has said, but also cuts across some quality improvement work that actually gets done in some of the other grant portfolios.
Don?
That's helpful. And go ahead.
Well, and I wanted to add, so I love the quality measure. Jeff always speaks of this so well. I think safety is our bedrock here at AHRQ. But we've talked with the NAC before, and maybe we'll do it again at the next meeting. The learning health system is the concept that we're using right now to move forward this idea of bringing together data and research and quality in a culture, patient-centered way, and putting them all together. So often the way we try to explain it to people, safety is part of it. Often, as Jeff has said, it's an on-ramp for people. But how do you build systems that use information, both that they generate and the research that's out there, and apply that continuously in a way that tomorrow's patients will be cared for and have better outcomes because of the work that the health system did today? And so it's one of the ways we've tried to bring that we do quality and safety together is, in addition to our data work and our research work, it's practice. And our practice is now being talked about in this meta concept of moving the systems to being learning health systems.
And we're going to pick up on that, on David's point, when we talk about the future of health services research and its relevance to the C-suite this afternoon.
I've been reminded by Jamie, thank you very much, that there are certain housekeeping things I need to reiterate. Number one, there are people on the phone. What you say is part of the public record. I tend to talk extravagantly and extemporaneously, and I get myself in trouble sometimes, and I don't want that to happen to you. So there are people on the phone, and which is a great thing. This is a public meeting. Secondly, don't forget lunchtime, photos for the new people, and transportation for anybody that's going to need it. Is that, did I do it?
Yeah, you're fine.
Okay, good. Okay, Sheila.
This is Sheila Burke. Don, observing your comment about ties, I would also note that there's a certain east-west divide with a couple of exceptions that anyone from the West tends not to wear. In fact, the fact they have on long pants is compelling.
I think the definition of West is the Potomac River, looking
Yes,
at,
exactly.
at Jerry.
As a kid born and raised in San Francisco, I can honestly observe that. I want to go to the last question that's been asked, which is how to make data more actionable and address local, state, and national priorities. A number of the comments that have been made to date, I think, are useful on this point, and the last note I thought was quite interesting. But it seems to me that the first question we need to ask ourselves in answering that question is, who's the audience? Because the answer to that, in terms of how one makes something actionable, is really a function of to whom you're giving the information, with what expectation in terms of response. And I think one of the challenges, and I was struck yesterday in our orientation, which was quite good, about the discussion about evidence now and the fact that you were working with very small practices and looking at not the big multi-specialty groups or the big learning health systems, but rather very small practices. And it would seem to me that the question, the magnitude of the information that is collected, a question of what the burden of that is on the individual provider outside of a big organized system. I mean, for Intermountain to collect information is not, or Pitt to collect information is not a challenge, but the guy in Osawatomie, Kansas, it's a real issue. So the question is, what are we collecting, from whom? And do we understand what the challenge is in terms of the collection, and also the magnitude of the data once received and then given back? Do people know how to use it? And Kathy made a point earlier. I mean, this question of, once we've given it to them, what do they know about how to best to apply the information they've received? And I think one of the things in answer to that question for AHRQ is, how do we think about who we're giving the information to and how do we want them to use it? And I think we can't lose sight of, one, people outside of those big multi-specialty clinics or those big practices who have people who can help organize it. I mean, Andrew's got a whole system of people that presumably work with their physicians and nurses and others. But in many settings, 2, 3, 4 practitioners or others, it's a much more challenging environment to figure out how to help them use the information, how to apply the information, and essentially how many metrics and how many of them are important to the practice that they're involved in. So I think we need to keep those things in mind. And I also think we can't lose sight of the fact that we're trying to move it to the patient. And that is, to what extent are we also providing information in a form that can be utilized by patients in making good decisions? I mean, one of the principles of moving to a value-based system is one where the patient has a role in deciding what's important and making decisions. And I think we can't think about this data. It's enormously important, enormously helpful to states, to state Medicaid directors, to large ACOs and others. But at the end of the day, it ought to be available to the physician or the nurse practitioner or other primary providers in those settings, because so much is moving out of the acute care setting into a community-based setting, but also to the patient. I mean, how does the provider talk with the patient if the patient doesn't fully understand what the data is or how important that data is to them? So I think one of the ways to answer that question is, in fact, to think about who's the audience, how will they use the information, what kind of information will be important to them, and how do we help providers translate that in working with patients so that they understand the full impact of the information we're gathering and the evaluations we're making about what best practices really are. So I think going forward in that changing healthcare system, that's going to be enormously important. It's not all going to take place in a box in a hospital. It's not all going to be driven by the doc. It's going to be a multi-interdisciplinary team, and the patient has to be involved in all of those elements of how we decide to use the information.
So that's very helpful, and it won't be a secret to some of the people at the table from AHRQ, but I've often looked some of the AHRQ displays and said, wow, you know, if I'm sitting here trying to figure that out, imagine what a patient or a primary care physician is going to do. So I think that's really important. There's a whole, obviously, science about that, a human-centered design aspect to it. So that's maybe a field for AHRQ to spend more time. I do have a question. I believe you're on the board of the Commonwealth Fund, and Maureen, by the way, sends her regards. The Commonwealth Fund deals with a lot of data. And I think your primary audience is probably policy. So how do places like the Commonwealth Fund work with the federal agencies around the kind of data you're collecting and the target audience? Because for these guys, what they do is policy relevant, because you heard what Francis had to say. I mean, we have to attribute it back. We have to make a compelling case. Gopal always talking about the pitch. So what can places like Commonwealth Fund contribute to this dialogue?
Well, I mean, and I can make the observation, one, sitting on the Commonwealth Fund board, but I also chaired the Kaiser Family Foundation board for a number of years, and have had a fair amount of exposure to Peterson and to the Arnold Foundation and others. And a secret asset, not so secret, is that Mark Miller is now at Arnold. In a conversation with Mark about how he thinks about it, having been on both sides, having run MedPAC, and now working with the Arnold family about how you use information. But it would seem to me in the context of Commonwealth, and David Blumenthal could certainly tell you this, there is a constant conversation that occurs between the agencies and the folks at Commonwealth in terms of what they fund. We fund in terms of demonstrations, what we fund in terms of the kind of research questions that we're asking. We use the information from AHRQ and from other agencies in terms of building the base. I mean, the conversation about essentially what HCUP and MEPS and all of them provide to us is used extensively, not only by Health Affairs, but certainly by the researchers that are on staff at Commonwealth, but also in the folks that we fund. I mean, because we fund a fair number of programs, whereas Commonwealth is different from Kaiser in that respect. So there is a constant set of conversations about what's important, what are the questions being asked, how can we demonstrate scaling, how can we demonstrate in place the kind of things that are occurring. And a number of the folks, of course, that work in both places came out of the agencies. So they also know the folks with whom they should talk. So the information is critically important. I mean, Commonwealth is relatively small in terms of foundations. It's not RWJ. And so they depend a great deal on information that they gather from the agencies and others. And it's enormously important. But again, I think it's that constant conversation between our researchers, the folks that we're paying to do the demonstrations and research, and the Commonwealth staff and others.
That's helpful, and I think worth making more broadly known. I don't think we've ever really talked about the relationship between foundations and the agency around data and measurement. And for example, I'd love to hear about the relationship with RWJ and the culture of health. I mean, they're using all kinds of data on culture of health, especially around social determinants and health and well-being. So maybe we could add that to future agenda with some sort of map of how you leverage that. Okay, thank you, Sheila. And Christina.
Hi, it's Christina Calamero. I have a comment, and then actually my question is one for Joel about what kind of challenges do you face? So it's a follow-up question to that. I think kind of tying in a little with what Sheila said and a few conversations around this table as we talk about being more patient-centric. And again, how are we disseminating so that information gets to the table? I can't thank you enough for your comment as someone who still practices now a very small amount on a Saturday morning, a couple times a month with patients. I utilize the clinical guidelines and I may explain it to patients, but how can we make it more relevant so that they understand where we're also getting it? I think just a brand AHRQ so patients understand, wow, that's an organization that's helped me be better. And also I think being patient-centric means looking at other models of healthcare delivery. And I wanted to thank Bob for his comments. I think of something very small that I think may be quite relevant is when I got to Children's Healthcare of Atlanta, they started in a more stringent way, patient-centered rounds that include at the bedside with the parents and the nurses delivering their report. And, you know, there still to this day, if you look at the data, there's not great metrics around that. But we tied in some outcomes that we're measuring now that are really starting to see maybe some qualitative work where parents will chip in much more frankly now that they feel comfortable with the nurses. The nurses understand what's needed at discharge. They know what community organizations that they need to mention to the social worker to engage. There's better discharge planning, which means potentially better readmission rates. So I think it's a very small thing, but you know, looking at the process of how nurses work, of how physicians work, how decisions are made, I really think can impact patient quality and safety. And then that's my comment. I think we need to be a little more broad in what we look at, because when I look at this list of our data users, it's a great list, prestigious, but it's very physician-centric. You know, we're publishing in physician journals, which I mean, I value my physician colleagues, but I think we really need to think more broadly about a huge sector of healthcare are your teammates who really need to hear about what AHRQ can give them. And then my question is, and I like what Lucy said about being a data steward. What's come up quite a bit we have a pediatric institute with Emory, we have a partnership in Georgia Tech, and what's come up with is data sharing. And I think it's very interesting, the Netflix case, some of you are probably aware, has come up where Netflix had a contest, I don't know if anyone saw that, where they gave de-identified data to 6 teams, I think it was. And based on 6 movies, they were able to de-identify 99% of the users of all this de-identified data. So security officers see that and kind of panic that we're handing out big data. But I think AHRQ has worked for decades with big data. So as part of our branding, we are the experts here on how to handle big data when, you know, so many institutions are worried. And those of you who are leading systems can let me know if I'm off with this, but we are the experts in managing big data. And how do you do that without de-identifying the patient, I guess? And I think that's the question, at least, you know, as we give out data to our partnering institutions, there's a real worry about, as we give it out, what are we violating? Who can de-identify this? You hand it to a graduate assistant after the professor's looked at it, that's on another computer. So I think that's a good way maybe that we can brand AHRQ is, hey, we've been data stewards for so long. We're experts, come to us, partner with us on how to handle big data sets, because I can tell you, our institution would probably like to build a moat and a wall around their data to protect our patients just because of worry about HIPAA violations. So I'm curious if you think if that's a challenge that we can kind of optimize with our network to say, hey, come to us, talk to us about how to build your big data or utilize it.
Yeah, as I said earlier, the chief technology officer has been looking at this for the department, and they've actually sent people around to talk to different agencies as to how they handle things, and they did come to us. And, you know, we have a history of how we handle the data. And, you know, they like the way we do it. You know, as to how generalizable that is, that's another question. And it's an issue that everybody is facing, because really with data these days, it's going in 2 different directions. There's, well, we need to link everything, and we need to put it all together, and we need to, you know, get this data and that data, and we have to do it at the person level. And then, but that's, wait a minute, you know, these are privacy concerns, and it's really critical that, you know, you not let my individual data out. And so, you know, they're working in opposite directions. They're trying to figure out how to deal with that. You know, the way we have dealt with it, well, we work with NCHS. So like for MEPS, our sample comes off of the National Health Interview Survey. So we actually, you know, when we put out a public use file, they have a disclosure review board. So we tell them every variable that we're going to put on the public use file, and they have a board that looks over it, and then they say yes or no to various things. And so, you know, we can't put it out unless they say it's okay to put it out. Now, our definition of public use data is the data that they've cleared to put out. And we put a lot of it out. If you look on our website, we've got, you know, tons of analytic files. And people do all sorts of research just using the public use files. But the public use files do not have a lot of geographic information. You can't link anything to it. You can't link even the area health resources file, so geographic data. So the way we handle that is to have a data center. We have a secure data center where, you know, we will, if you want to link something, we'll link it. You can use your file within the data center. You can't take out any individual data. So, you know, only, and that's the way.
Great? Yeah, that's what you described, right?
Yeah.
That's what we're good at,
Right.
is doing that. I think
Right.
that could be really highlighted.
Yeah. So, and there are private organizations that do this kind of thing too. United Healthcare, I know we've worked with them. They have what they call a sandbox, so they've got their own system, and you can go in there and do that. CMS, you know, you can get a license, a seat license, essentially. I forget what the enclave they call it, you know, where you can, you know, go into their system. But there are limitations on those. So, But this is what I was saying earlier about the data governance is, basically everybody does it differently. And, we've tried to work sometimes with the private organizations like United Healthcare. I actually, one of the things, we're talking about data linkages. One of the things I've always wanted to do is to be able to link our people to private claims data. Now, we know what insurance companies, what insurance they're using. We ask that question. I've never had any success in being able to actually link, the MEPS data to the private insurance data. And it's because I cannot give, because of the way it's collected and the laws and regulations under which we collect our data, I cannot give personal identifiers to an insurance company and let them link it. I can't give them the data. From their perspective, they have the same thing. They cannot give me their data personally identified. So we've never been able to do that. But these are issues that have to be worked through, and you really do have to worry about it because one of the things we worry about with MEPS is all you need is one case of somebody's personal identifiable data to get out, and your survey's done. So nobody will participate anymore. So.
The public, it's interesting. I had a conversation with one of my patients, and I work with a underserved population, and we had a conversation around, believe it or not, around did I think that we would move to, our system would move to Google or Amazon? And I looked at this guy like, oh my gosh, I'm seeing your kid and you're asking this question. I never even expected, but as we discussed, that's where he lives. He lives in hearing this, but I think about what we do and how we protect data here. And isn't that sad that, the Googles and the Amazons are going to be the ones who are the leaders, yet AHRQ has done this for years and we're not positioning ourselves as the leader in this area. But my young Hispanic male with a small child knew about Google and Amazon picking up on healthcare data, which blew my mind. And I think that kind of told me that we need to talk about even in a better way or somehow capture our ability to be experts with big data.
Right. Thank you.
I'm afraid so, yes. So, because it's almost like I'm putting us on the spot, but as I listen to the dialogue now, it occurs to me that acknowledging the current barriers to data linkage and also the realities of maintaining confidentiality and safety of the data, notwithstanding, it seems like we've got to get to a point where we talk about what are the steps to solving this problem. And we all know that a journey of 1,000 miles starts with one step. So I think maybe what we could talk about are what are the near-term next steps to get at some of the regulatory and other barriers that are real, but perhaps not insurmountable if we put our efforts to it.
It does seem like a critical priority. I don't know how well resourced or how much time you have to spearhead that, but
And so it isn't. And so Joel sits in a critical point with the Data Council. So it's not just an AHRQ issue. It's an issue that in the department we're all struggling with. Gopal has pushed us to. So I'm really just parroting Gopal here to tackle this issue. And I think it means we have to generate some will across the department and also with our data partners to figure out where's the sweet spot where this can happen to demonstrate that it can be done in a very safe and thoughtful way, and then maybe that develops some use cases to be able to broaden.
I mean, the risk, of course, is that somebody else will solve it for you in a way that you don't appreciate. And that probably won't take too long. By the way, just anybody who wants to spend some spare time really getting nervous is to read the piece in the New Yorker on AI in the most recent issue. And my wife called up and wanted to know if I was AI or actually her husband. So it's a fairly scary piece. So I think we've gone around, but we have a couple of, Karen and Monica have some comments.
Great, thank you. This is Karen Amstutz. Just one last point on the data stewardship issue is just to remember there's a whole patchwork of state regulations, some of which add to the confusion. And just to share an absurd example related to mental health data, as Magellan operates in the Medicaid business in Florida, we're required to get authorization and use disclosure agreements from every individual in order to actually share any data with the providers. So our ability as a payer to share meaningful data with providers is actually fairly limited. So there's this patchwork that really is quite impactful. I wanted to comment, one more comment on how to make data more actionable and address the critical issues is to really think about, I concur with the comments about ACUP or the HCUP data and making it more broad, but layering on analytic tools and standard metrics and maybe going one step further, saying data visualization standards, that would be really helpful. We have problems we would love to benchmark, for example, in patients with serious mental illness to really understand how HEDIS metrics or blood pressure control or metabolic syndrome control, get some standards, find out if we're actually making progress against national standards, and that's impossible to do in the current context without, and in a perfect application for AHRQ in terms of increasing the tools and then also thinking about how you visualize it.
Thank you, and I think Monica was next. No, yeah, you had your card up for. I'm trying to be a little more.
All right, I defer to your rules. This is Monica Peak. I just wanted to loop back onto a comment I made in the earlier session and to sort of drill down on that and to specifically address the first and last question up on the board around making data more actionable and the future challenges and questions that we see facing our healthcare system. And right now, what we're seeing are healthcare systems trying to incorporate screening for social determinants of health in practice. And then with the obvious follow-up of what we're going to do about things that we find out. So screening and then subsequently potentially addressing social determinants of health within the context of healthcare. And right now, the Queens, we have a sense that these are important things to do, but there isn't the same kind of academic and evidence-based rigor around some of the associations between these material needs insecurities and some of the health outcomes for a range of chronic diseases. We're not even sure what the best measures to screen for are, and CMS has been rolling out some of the screening tools. And so what we really need, what I personally really need, but what we all really need are a good sense of which tools work best, validated in different populations, which kinds of material needs insecurities are most associated with the greatest magnitude of change for different kinds of chronic diseases. And all of that requires study and data, but then helps us inform the action of intervention. And so I think that similar to the data integration, that's a big wall that we're bumping up against, is trying to figure out how to track these and whether or not they're closed loop systems for referrals that are going out to social service agencies. And, you know, there's a whole team of NowPow and Aunt Bertha and other systems that are being built up that are different and not necessarily speaking to each other in a similar language. So I think that there's a need for some consistency, some validation and measurement, and for more evidence base to inform action around what's already happening in our healthcare system to try and fold in the screening and addressing of social determinants of health to improve health of vulnerable populations. And so that's something that I think AHRQ can take an important leadership role in.
Great. I'm sensing there's a duality here. So one is better specifications and guidance on how to measure in a valid way social determinants and health, well-being, quality of life, and so forth. And there are all kinds of issues there around sampling and who gets to answer the sample in terms of equity. But the other side of the coin is we're hearing a lot about learning health systems here, and very few learning health systems are even measuring these things and may not, even if they had the AHRQ, or somebody's guidance on how to do it. So the challenge is really, I think parts of KP now measure well-being routinely, but it's pretty spotty, right?
I think a lot of people are doing it, but we're just absent the science. That's the problem.
I think I've just been to a bunch of these social determinants discussions recently, and I think we as a payer have a social determinants of health registry. So we capture from a number of different sites health risk assessments, care manager conversations, information on every one of our members about a variety of social determinants. I don't think we're alone. I believe there are, in particular, places where there are payer-provider collaborations, where the payer is able to actually capture information from clinical encounters. There's more and more effort around capturing that data. And I do think this is a point really well taken, that it's sort of the Wild West, and there's a big opportunity to kind of consolidate, create some standards, and sort of create a rising tide around this.
I think, Jerry, you were next, and then Andrew, and then Beth.
Great, Jerry Penso. I don't find it surprising that I find a lot of resonance with the comments from my colleagues here from the delivery system side, be it Will or Andrew or Bob or Lucy or Christina. What I see and what I'm hearing from medical groups and health systems, the large multi-specialty integrated systems, is that their future challenge they see is the move to value. And they see it in two different ways, I think. One, maybe the way we kind of think about it, total cost of care, that they're going to be accountable for the quality and the cost of care for an assigned or attributed population. So they're very interested in what are those cost drivers that are going to now or in the future affect their populations that they can then have impact on. But they also think of value as the operational cost. To get to those better outcomes, what are my internal costs, and are there more efficient ways to get there? So echoing where Bob was going, I think a role for AHRQ is not just understanding what are the best processes to get to that care, but how much are the costs? What are the cost inputs and the cost drivers of those different processes of care? They see a future world where their revenues are stagnant or going down, but their expenses keep increasing. Given that reality, they're going to have to look at expense reduction and what are they going to do to get to those better outcomes, yet do it at a sustainable price point. So I think that's the future world and the future challenge that our groups are facing, that I think AHRQ could play a pivotal role in helping them answer that question that they're going to need to answer in 10 years, or they're going to be, frankly, they're going to be underwater and out of and have severe financial challenges.
Let it be known that we've gotten into the third or whatever hour of our conversation, and value has finally risen its head.
And just one more point, which goes to the linkages. When it comes to those cost drivers, they're very interested in what they don't know, which is the social determinants, because they know, we've been working with claims for years and years, and they've gotten good at that. What they want to know is what else is out there that will be driving their costs. What are other insights, be it from electronic health record data, be it from social determinants, be it from, who knows, from Google location data, other things that will help them, again, manage that total cost of care and manage their internal costs.
There's just a subtext here, and Bob kind of put this in my head about the data we need that will help us deal with things like value and implementation, measuring processes, and so forth. And as you probably know, NQF has backed away from using process measures to focus on outcome measures because they're so difficult to collect, and they're getting all kinds of pushback from their customers in healthcare about the burden of measurement. So this is an area I think for AHRQ to really think about. I know you're very involved with electronic capture of measures, and that's an evolving field, but we ain't there yet, as best as I can tell, with really measuring compliance with the CLABSI bundle or whatever it is you want to mention. So that's a good provocation, but we're not there yet electronically, and we're moving away from it in the national measurement scene. So something to consider. I think now we're at, do you like to be called Andy or Andrew?
Either one works.
Okay.
So Andy Massica. So speaking to some of the data challenges, we've heard a lot about data sharing, transparency, data linkage, and also integrating some of the cost information. And I think the openness of the two different communities, the data science and research community, is very open to that. They know these types of things need to happen. I think where there's a gap and who shares a differing view, particularly at the organizational level, is the legal, compliance, and regulatory community. So the vision of data sharing and what we need accessible and the transparency versus the realities of trying to do that at a system level, I think there's a gap there. But in terms of what AHRQ can do to help fix that, I think specific initiatives that accelerate that data sharing can help close that gap. And two instances that I can think of from our own organization, so we're part of NIH's All of Us, so the concept of collecting genomic information, sharing that, that accelerated the internal discussions about how you go through a process like that. And also the PCORNet. We're also a site with PCORNet. So creating that aggregated data structure and the conversations that need to happen with information security, compliance, legal, discussions that might have taken 10 years just sort of evolving naturally. Those type of specific initiatives, when you put them out there and allow systems to pursue them, I think it accelerates how we can close that gap in terms of the differing views of the communities.
I keep quiet now because we're running out of time and I want everybody to get to speak. So do you like to be Beth or Beth Ann?
Beth is fine.
Okay.
Thank you. I just wanted to share that I see this from two different perspectives, and I look at it from an operational perspective. You talk about data collection for the small private practices. I think at the state level, we have seen that happen from the payers because they're collecting the data from the office practices. We're putting the resources into collecting that data for the payers, because with that, they provide us an incentive when we give them that data. So it's been very beneficial for us to work with the payers to give them the data that they need from an office practice and from a patient perspective to give them that continuity of care across the continuum. So that's one thing in a small rural area that is a benefit for us. The other thing is the cost of the data. When you're small and rural, you have a lot of agencies that AHRQ interfaces with. I'll say Sheila did an excellent job of what Bob referred to as an elevator conversation. She shared her elevator conversation very well on the Commonwealth. When you think about AHRQ, most people don't, that are in the day-to-day operations of healthcare. They see all those agencies who use AHRQ, and that's where they see their data coming from. So I think Bob was spot on when he said AHRQ needs to develop their elevator conversation. Who was it?
It doesn't matter.
Oh, Lucy. Sorry. Bob and Lucy both talked about it. We've gone around so many times, but I think they were spot on because the users in healthcare across the continuum do not recognize that AHRQ is the foundation for that data. They see CMS as that person, they see the CDC, they see those as the fundamental agencies that's providing the data. So it is creating that elevator conversation.
A couple of, what happened? Oh, you didn't, okay. So Tina.
Yeah, so I just want to make a comment in regard to Jerry's comment and what you said. So we've had a lot of conversations to talk about the need for different measures that are really getting at what we care about. We've talked about this merge to, or we've moved to EHRs and big data and electronic data and the burden of getting these process measures. And so there was a big push a couple years ago about these e-measures. And you know, I'm not sure, and I haven't followed it because I just haven't, they're very difficult to use. And I want to question to you, you know, what's AHRQ's stance on moving to e-measures? Is there any progress in that area? And is that something that can address some of these issues when we start carving out our space for identifying measures that matter, measures that can get at some of these different pieces of data?
So in addition to working on the data enterprise efforts, I also lead AHRQ's quality indicator program, which is our quality measurement initiative based off of HCUP data. So we have engaged with the National Quality Forum for years on our patient safety indicators. We worked with CMS and others, and under meaningful use, there was an initiative where we took some of our indicators and tried to translate them into SNOMED and others. And that was a very, very difficult task. Part of the issue there is that, you know, we need to really think about this from a measurement side. We depend on there being standards on the data side. And until there are standards on the data side, particularly with the EHRs, I think we're a little hamstrung. I think from a futuristic perspective, I think there's a lot of groundwork that needs to be done first before we can go into that space. But the EHR does obviously provide an opportunity to get a lot of really good measurement initiatives going, but I don't think we're there yet. I think internally at AHRQ, we have been having conversations, but just about strategic thinking around quality measurement. What is AHRQ's role? As Francis mentioned before, you know, we have the PQMP, we've got CAPS as a measure initiative, we have the quality indicators. We do a lot of evidence generation through our grants process around quality metrics as well. But I think in terms of EHR-based measures specifically, I think we're still waiting for that standardization sort of thing to happen, because on the administrative data side, we have that, right? So that's why the quality indicators exist, because we do have a standardization of administrative data available to us to work from, so that when we do quality measurement, you know, when we build a specification, you can implement that and with any hospital discharge data set. I don't have that available to us in the EHR world.
But is this somewhere where AHRQ interested in saying, you know, in order to measure this patient-centered metric, or in order to move this forward in a more efficient way, this is the standards we need to create this measure, something like that?
So I think at the department level, we need to have that conversation, because it's not just AHRQ, it's our colleagues at ONC as well. My colleagues at the HIT team here at AHRQ are also working with their colleagues at ONC from a research implementation perspective on the HIT side. So we do have work happening. I don't think we're quite there yet. And I think as we continue thinking about AHRQ's role in quality measurement, we need to have that conversation.
Oh, we have two more. Well, we're approaching the Korean rice bowl guy hour, so if he's there, can you arrange, get the Korean, go get him.
Follow up with your last comment, Don, and Tina's comment. The measures I was thinking about weren't necessarily measures that we would impose on everyone or would be ultimate markers of quality. But these are measures to help the systems get better. And that AHRQ might, through R1s and investigator-initiated research, promote the building of such a catalog, so that if you're trying to improve care, you would have a catalog of these that you would use and understand care, and then you'd get your processes and you might not continue to collect them. So often we talk about outcomes, like patient-reported outcomes, but we miss these covariates, like health literacy, health numeracy. Not an outcome so much, but very important determining variable that if you don't understand, you're going to miss the connections and you're going to attribute the wrong things to each other because you're not looking at that. So when you say, well, national quality forums move to these and not these, I'm not thinking about these as being those endpoints, but we don't know how to measure, we don't know what to measure to try to understand processes. And that kind of work, I think, could really be flushed out, not imposed universally, but available when used in a targeted fashion to improve care, moving in and out.
Okay, let's briefly Jose and then Alice, and then I'll sum up and we'll have lunch.
So I'll try to be very quick. Having earlier sort of made this, tried to make an argument for the breadth, the importance of breadth in health services research. This conversation has been really interesting, and I'm just going to talk about 4 subjects that bring together sort of the need for, I guess, what we might call fundamental or basic research, as well as very applied research, and I'll just list them out. So the first is, we heard that there's movement from process measures of quality to outcome measures. What are the implications of that? One of the virtues that have been touted for process measures for a while is that, well, you don't have to do much adjustment. You obviously have to do huge adjustment for outcome measures. So what are the implications of moving from process measures to outcome measures? That's number one. Number 2 is we know that health systems are trying to sort of get involved in social determinants. Social determinants, many of them are things that play out over the life course. What is the scope for health systems to intervene in social determinants? How much can they really do? Surely there are some things that come to mind and that they're already doing, but what are the limits of that? And to what extent is the health system being, I'll just use the word saddled, given the responsibility for curing things that, that just like the educational system has been giving the responsibility for dealing with social determinants of low educational achievement. So number 3 is, in talking about this value issue, I mean, we think there's waste in the healthcare system, as if that waste gets eliminated, or even if not all of it gets eliminated, there's certainly, providing higher quality is likely to cost more money. Where does society want to stop? What is the trade-off that society wants to make about the money spent on healthcare versus the level of quality of care? And then finally, what exactly is providing patient-centric care? I mean, patient-centered care or patient-centric approach. I mean, there's plenty of evidence that patients bring enormous cognitive distortions to decision-making in healthcare. That's not surprising. It's a very fraught situation, a great deal of anxiety, a great deal of fear. And the evidence about, magnification of certain probabilities, myopia, short-term biases is huge. So is patient-centered care sort of a radical deference to patient preferences? Or is there, and how do we deal with the fact that we know that patients bring these cognitive distortions? So how do we measure patient-centered care in that context? So I think those are all fascinating questions, and they involve both things that are very applied in the end, but that really require some much more fundamental research of very different types and contributed to by very different disciplines.
Thank you. That's really deep thinking, actually. Thank you. Alice, if you have any cognitive
Alice
disorders.
Fast. Yes, I just wanted to echo a little bit what Jose said on his last point of really what, do we have a standardized definition of what patient centricity is? Is it well defined? Because I think that's important. I was on a committee looking at the standard definition of patient engagement, and we found that it was all over the board. So I think that's important that when we use the word patient centricity, that we use the same language and the same definition.
That's an excellent point. I have a AHRQ T32 training grant, and every time there's an issue that has the word patient in it, somebody wants to use the patient activation measure, which is a measure of one specific component of engagement, activation, self-efficacy, and so forth. So I think that's a very useful point. Thank you. So we are now at the magic hour of lunch. I did jot down a couple of thoughts that'll take maybe 2 minutes to give. If I were sitting here, I would say, wow, we asked for input from these really bright people from a multitude of perspectives, And we're a small agency, and we can't, they want us to solve world hunger and to bring together all the other agencies and to make partnerships with Google, for crying out loud, and with all these foundations. And well, come on, here we are. You can look around the room. We're here. So you must be really, appropriately activated but concerned. So just a few things that I.
If I may interject, or excited, because the greatest amount of innovation happens from the bottom of the pyramid as well as by small players. So
Yeah.
just in case.
Okay, that's I totally agree with you. You're agile. You're like the rabbit in my garden. You managed to eat my carrots, so I chased the rabbit with a rabbit repellent spray, which has cayenne pepper, and the wind blew back into my face.
Did you get that on video?
I wish I had. So just a few thoughts. So this issue about the partnerships, I think, is really, really key. And it would be great for you to reflect on this and maybe come back with some strategy around which partners and at what level and what depth and for what purpose. So partnership and service of what and with whom by when, I guess, would be a way to think about that. The lot of talk about HCUP and MEPS, and as we mentioned earlier, it's a large part of your budget and your remit from Congress, actually. But there are other data needs and gaps, and this idea of following the patient through the course across the continuum of care, and where do HCUP and MEPS help, and where are there additional needs, and what's realistic in that regard. And then this issue of big data, I don't know. I'm actually not sure that AHRQ does have the experience to really understand and play in the new digital age yet. So to what extent do you want to be really deeply knowledgeable about that, so you can be an equal player in this dialogue? And to what extent are you willing to move from hypothesis-driven research, which is a feature Tina and some of us were discussing, feature of every grant request or contract now is, what's your hypothesis? Well, big data is not hypothesis-generated research. It's exploratory hypothesis-generating research. And that's a paradigm shift, really. If that's the field where you want to be moving to, I think it changes your view of what health services research can be. It doesn't mean you exclude hypothesis generation. Jose would rise up if we did that. But it's something to at least think about. And then this agility, and how do you preserve the basic science, as it were, of health services research, the enduring questions that we must answer and keep in mind, versus the agility to deal with a rapidly changing health system in a data-driven age. So all this relates to data, and choices will be made because you are a small, agile agency, but you're small. And you can't be good at everything. IHI, we once had this debate about what we were good at and what we were really world-class in. And we haven't solved that. We still think we're world-class in everything, but no, we are not. And neither are you going to be world-class in everything. So it would be fun to have you reflect and maybe come back and we can digest your strategic thinking around this and maybe give a second round of input. And we still have other dialogue. We're going to use opioids as a lens, right? And then we're going to talk about what does the C-suite and leadership and healthcare delivery expect and need from AHRQ. Is that fair? I didn't want to put work on, but I think that it's been a wow. Yeah. Okay. Thank you very much. I really appreciate your willingness to talk at such length and depth. Oh, don't forget pictures, transportation.